Vanakkam. Before we start talking about the different clinical features and the management of congenital hand differences, we need to classify the problems. Or should we? Why should we classify the problems? Why not just start managing the problems right away? And having decided to classify the problems, what classification system should we use? There seem to be so many systems available for classification of congenital hand differences. Which is it that we should use? All these explained in this video. In this video, dealing with the classification of congenital hand differences, we shall first see a short introduction, the history of the different classification systems available, the IFSSH classification or the International Federation of Societies for Surgery of the Hand, their adopted classification, and finally the OMT classification. It is important to have a good classification system for congenital hand differences because congenital anomalies in the hand and upper limb demand a reproducible and consistent terminology, that is, a universal language which allows discussion of complex clinical entities, indications for treatment, and comparisons of results. Attempts at making classification systems for congenital hand differences have been going on for many years. Perhaps the first classification system was probably that of Isidore Saint Hilaire in 1832. In this system, terms such as focomele or seal limb, hemimele or part of limb missing, and ectromele, limb absence, were used. The France and O'Reilly classification was based on skeletal appearance and was made in the year 1961. It was this system that introduced the concepts of terminal and intercalary defects, subcategories of transverse and longitudinal deficiencies, and including the involvement of pre or post-axial position within the limb. Kelikian in 1974 summarized the contributions of many authors in his classic text The Congenital Deformities of the Hand and Forearm, but acknowledged that we have not as yet attained enough latitude of knowing about congenital hand anomalies to formulate a comprehensive classification. This was because though different classification systems were available, they could be divided according to their basis of foundation, descriptive, anatomic or topographical, embryologic, teratogenic sequencing, genetic, and different combinations of these. The International Federation of Societies for Surgery of the Hand, IFSSH, accepted the surgical classification of upper limb anomalies based on the proposals of Swanson et al., which had been made in 1968. Swanson himself refined his system in 1976 and then in 1983. This IFSSH classification based on Swanson's method consisted of 7 categories: failure of formation of parts, failure of differentiation, duplication, overgrowth, undergrowth, constriction band syndromes, and finally generalized anomalies and syndromes. Under the failure of formation of parts, there were 2 categories: transverse arrest and longitudinal arrest. Longitudinal arrest could be a radial club hand, which was a pre-axial arrest, ulnar club hand, which was a post-axial arrest, a cleft hand, which was a central arrest, and focomelia, which was an intercalary arrest. The second category of failure of differentiation consisted of syndactyly and contracture. The contracture could be a clinodactyly, camptodactyly, trigger thumb, congenital clasp thumb, Kerner deformity, arthrogryposis, or synostosis, which were all included in this category of failure of differentiation. Duplication was the category under which polydactyly was included, which could be either preaxial polydactyly or postaxial polydactyly. Overgrowth included macrodactyly of the fingers. Undergrowth could include the hypoplastic thumb or the Madelung deformity. Constriction band syndromes had their own unique features and were included in a special category for themselves. The seventh category was generalized anomalies and syndromes, which included innumerable syndromes including the Poland syndrome, Apert syndrome, Haas syndrome and the Freeman-Sheldon syndrome. This IFSSH classification was further expanded by Knight and Kay in 2000 and by Upton in 2006. In the Swanson classification, which was the basis of the IFSSH classification, each limb malformation was classified according to the most predominant anomaly and is placed into one of 7 categories that we have seen. It has definitely been of significant benefit, but it remains based on a morphological rather than etiological system, and so this system is unable to adapt to increasing knowledge. In 2014, the committee recommended adoption of a revised classification system for congenital anomalies of the hand and upper limb, as proposed by Drs. Kirby Oberg, Paul Mansky, and Michael Tonkin, popularly known as the OMT classification. In keeping up with the increasing research and information regarding the development of congenital hand differences, there was an update to this system in 2015 and again in October 2020 when the update was prepared by Charles Goldfarb, Mary Beth Ezaki, Lindley Wall, V. Lamb from the UK and Kirby Oberg from the USA. The basis of this OMT classification is that all congenital differences are placed within one of 3 groups according to the dysmorphology. Dysmorphology is a discipline of clinical genetics that studies and attempts to interpret the patterns of human growth and structural defects. So all congenital differences can be placed under the group 1, which consists of malformations, group 2, which consists of deformations, and group 3, which consists of dysplasias. So what is the difference or significance of these 3 terms? Malformation is an abnormal tissue resulting from abnormal cell formation. Deformation, on the other hand, is the insult to cells which have already formed normally. So, a deformation occurs of the normal tissue. Dysplasia is a lack of normal organization of cells into tissues. So, the dysmorphology could mean malformations, deformations, or dysplasias. Let us first consider the malformations. These malformations can be classified according to whether they involve the entire upper limb, and this occurs due to abnormal axis formation in the early limb patterning period, or the malformations could involve only the hand plate. So here it is abnormal axis differentiation and it occurs during late limb patterning or differentiation. First, let us consider malformations involving the entire upper limb, which is abnormal axis formation. As we know, there are 3 axes of development, so the malformations could involve the proximal-distal axis, the radial-ulnar or antero-posterior axis, the dorsal ventral axis, or any unspecified axis. When malformations of the upper limb involve the proximal-distal axis, it could be brachymelia, symbrachydactyly spectrum with ectodermal elements, transverse deficiency without ectodermal elements, intersegmentary deficiency, that is phocomelia, or whole limb duplication or triplication. The first category, that is brachymelia, refers to a shortened upper limb completely, as occurs in the syndrome called Robinov syndrome. The second category of symbrachydactyly spectrum with ectodermal elements is seen in the Poland syndrome, or it can be seen with whole limb involvement excluding Poland syndrome, that is, at various levels from the clavicular level to the phalangeal level. The third category of transverse deficiency without ectodermal elements could be an amelia or a total absence of the limb beyond a certain level, or segmental occurring at various levels from clavicular level to the phalangeal level. Intersegmentary deficiency exemplified by phocomelia can also occur. This could be proximal phocomelia, that is, a missing or shortened humerus which is said to be rhizomelic. It could be distal phocomelia where there is a missing or shortened forearm which is known as mesomelic, or it could be shortening of both proximal and distal segments where the hand is attached to the thorax. The final category is whole limb duplication or triplication, which is a rare occurrence. So after considering malformations of the upper limb in the proximal distal axis, we shall now consider the malformations occurring in the radial ulnar or anterior posterior axis. There are 7 categories of malformations that can occur in this axis: radial longitudinal deficiency, ulnar longitudinal deficiency, ulnar dimelia, radiohumeral synostosis, radio-ulnar synostosis, congenital dislocation of the radial head, and forearm hemiphyseal dysplasia, which could be radial or ulnar. So, considering the malformations of the upper limb involving the radial ulnar axis, the first category is the radial longitudinal deficiency, and the classical example of radial club hand falls under this category. Under the category of ulnar longitudinal deficiency, the ulnar club hand is seen. In ulnar dimelia, there is a duplication of the ulnar side of the hand on the radial side. Radiohumeral synostosis is characterized by fusion of the lower end of the humerus with the head of the radius, and radio-ulnar synostosis refers to fusion of the proximal ends of the radius and the ulna. Congenital dislocation of the radial head also falls under the category of radial ulnar axis malformations involving the entire upper limb. The final category is the forearm hemiphyseal dysplasia. This could be a radial involvement which is called the Madelung deformity, which refers to bowing of the radial shaft with increased interosseous space and dorsal subluxation of the distal radio-ulnar joint. This deformity is due to premature closure or defective development of the ulnar third of the distal physis of the radius. This hemiphyseal dysplasia of the forearm bone could also involve the ulnar side. The third described category of malformations involving the entire upper limb refers to involvement of the dorsal ventral axis. Involvement of this axis could present either as ventral dimelia, that is, appearance of palmar structures on the dorsal aspect of the hand, or dorsal dimelia, that is, the appearance of dorsal structures on the palmar aspect of the hand. Apart from the 3 described axes, the malformations involving the entire upper limb could involve any unspecified axis also. This could involve either the shoulder or an upper to lower limb transformation. At the level of the shoulder, there could be an undescended shoulder known as the Sprengel shoulder, which is characterized by a small and undescended scapula, often associated with scapular winging and scapular hypoplasia, or alternately presence of abnormal shoulder muscles. Congenital hand differences in the form of upper limb to lower limb transformation can also occur in this unspecified axis. We have now completed the classification and subcategories of malformations involving the entire upper limb. We shall now see the classification of malformations involving the hand plate only, that is, resulting from abnormal axis differentiation. This too could involve the proximal distal axis, the radial ulnar or anterior posterior axis, the dorsal ventral axis, or an unspecified axis. Malformations of the hand plate involving the proximal distal axis is divided into four subcategories: brachydactyly, symbrachydactyly with ectodermal elements, transverse deficiency without ectodermal elements, and cleft hand, otherwise known as the split hand-foot malformation. Brachydactyly or short digits is a general term that refers to disproportionately short fingers and forms part of the group of limb formations characterized by bone dysostosis. Brachydactyly can occur either as an isolated malformation or as a part of a complex malformation syndrome. Symbrachydactyly with ectodermal elements involves fusion of the short fingers, and transverse deficiency without ectodermal elements may lead to complete loss of development of the hand plate. The cleft hand or the split hand-foot malformation is characterized by clefting of both the hands and the feet. Malformations of the hand plate alone involving the radial ulnar or the anterior posterior axis is subdivided into six categories: radial longitudinal deficiency, ulnar longitudinal deficiency, radial polydactyly, triphalangeal thumb or the five-finger hand, ulnar dimelia or the mirror hand, and ulnar polydactyly. In radial longitudinal deficiency, there is a malformation of the tissues on the radial side of the hand, resulting in the classic hypoplastic thumb. This deficiency can manifest on the ulnar side in ulnar longitudinal deficiency, where we can see a hypoplastic ulnar ray, where there is a deficient development of the ring and little fingers. In radial polydactyly, there is a duplication of the fingers on the radial side, here the thumb, and in a triphalangeal thumb, which is otherwise known as a five-finger hand, the thumb has three phalanges as against the normal two phalanges. This gives the appearance of a finger to the thumb, hence called the five-fingered hand. Ulnar dimelia or mirror hand is the situation where the ulnar side of the hand, that is the index, middle, ring and little fingers, are duplicated in the same hand. The sixth category of ulnar polydactyly is characterized by polydactyly involving the post-axial border, that is the ulnar border and the little finger. Malformations of the hand plate can also involve the dorsal ventral axis of development of the upper limb in the embryo. It could be a dorsal dimelia where a nail is seen on the palmar aspect, that is, the dorsal structures are seen on the volar side, or a ventral dimelia where the structures that normally develop on the dorsum are either aplastic or hypoplastic, like the nail development. Involvement of an unspecified axis can also cause malformations of the hand plate. They are classified into involvement of the soft tissues, the skeletal tissues, and complex involvement. An example of involvement of soft tissue is simple syndactyly, where there is no bony union between the two fingers that have been fused. As far as the skeletal involvement is concerned, there are many variations. There could be a syndactyly where the bones are united, otherwise known as osseous or complex syndactyly, a clinodactyly where the finger is bent to one side in the radial ulnar axis, Kerner deformity where there is a deformity of the terminal phalanx of the finger alone, or a synostosis or symphalangism where the joints are congenitally fused. Complex involvement of unspecified axis causing malformation in the hand plate could be a syndromic syndactyly, example the Apert syndrome hand, a synpolydactyly where there is a syndactyly but there is a duplication of fingers within the syndactyly, or any other malformation that is not otherwise specified. So now we have seen the classification of malformations which could involve the entire upper limb and the hand plate. Having completed understanding the classification of malformations, we shall now go into the classification of deformations. Deformations are basically of two types. They could be a constriction ring sequence or they could be a deformation not otherwise specified. This category allows for new deformations to be added as they are being reported. The constriction ring syndrome, of course, has all the features like lymphedema, constriction bands, amputation, and even acrosyndactyly. That covers malformations and deformations classification of the dysmorphology of congenital hand differences. What remains is the classification of dysplasias. Dysplasias can be diffuse, that is, involving the whole limb or isolated. Diffuse dysplasias involving the whole limb can be seen in the condition called hemihypertrophy of the entire upper limb or in the form of aberrant flexor, extensor or intrinsic muscles. Isolated dysplasias can be seen in the form of macrodactyly involving individual fingers or involvement of aberrant intrinsic muscles of the hand alone. So now we have seen the classification of dysplasias also. We need to remember that classification of congenital hand according to the OMT classification. The basic congenital difference we see could either be malformation, deformation or dysplasia. For more details about the OMT classification which is present in the IFSSH website, please scan the QR code for Android users and Mac users. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about congenital differences, especially the surgery of congenital syndactyly. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.